Hello everyone, and welcome to this webinar, Putting People at the Heart of Social Work, Learning from the Named Social Worker programme. We're really pleased to be talking with you today about what we've learned from the programme, about what it takes to deliver a named social worker model, but also about what difference it makes to people with learning disabilities, with autism and with mental health needs. And really pleased to be joined today by Lyn Romeo, Chief Social Worker for England, by Tony Hunter, the Chief Exec of the Social Care Institute for Excellence, and by the fantastic teams from Halton and Liverpool who have been delivering these pilots on the ground. So I'm going to do a quick overview of what we're going to discuss today, and then I'm going to hand over to Lyn to help introduce kind of what the programme is and where it's come from. So the first thing I'm going to talk to you about will be the introduction to the named social worker. So as I said, Lyn's going to do an introduction to the named social worker. Then we're going to move on to thinking about what the programme has taught us, what are the lessons from the programme, and then we're going to have a Q&A with some of the sites that took part, as I've already said. And then finally, Tony Hunter from SCIE is going to tell us about what this means going forward. So in terms of the webinar software, you'll see there's a chat function on the right-hand side. I've seen lots of you have already started chatting away, and hopefully you can all hear me clearly. And we are going to there's going to be a couple of opportunities within this webinar for you to both share things that you're thinking about this, but also ask questions to the people participating. And the third thing that you'll be able to do is kind of have a go at some polls that we're going to be testing out, just so we can get a sense from the whole audience of what you're doing. So let me just grab the mouse so that I can flick through to the next slide. And we will ask you the first question. So the first question I'm going to ask you today is, what do you want to get out of this webinar? And if you could take away one thing, what would it be? So I'm going to encourage you, this is just to kind of warm everyone up and get everyone using the chat function. If you could just share the first thing that comes into your mind in relation to this question. Have a go at tapping it in, and you can see both what you're interested in, but also what the other people who are watching it interested in as well. I'll give you a couple of minutes to do that. And we've got, let's have a look, we've got 58 people attending so far, which is brilliant, and I can see that everyone is tapping away, and hopefully people can hear me clearly. So we've got people interested in what's happening across the country. We've got people interested in the benefits of the approach, but also kind of the really important side of the evidence for the models, which we'll definitely be going into later on. So I'm going to let everyone kind of continue asking those questions and sharing the kind of their priorities for what they want to get out of the webinar, and I'd encourage you to keep doing that as we go through. But for now, I'm going to hand over to Lyn Romeo to help give us an introduction as to what the programme is and where it's come from.
Great, thanks Chloe, and hello to everyone out there. This programme, which was led by the Innovation Unit and SCIE, focused on testing ways to give people with learning disabilities, autism and mental health needs a stronger voice. And I believe that that could happen through designating a social worker to be their key point of contact and to have the time and capacity to build a relationship with the person in order to really understand and get to know them and know what would be the things that really matter to them and how they could work holistically and in a tailored way with them to really help them to have the lives that they wanted. This would also mean working very closely with their family and carers and the networks of support that the people had. There wasn't a prescribed model. Instead, we invited the sites to share the approaches that they wanted to develop in terms of what was happening locally, their local context, initiatives and challenges that they faced. So for me, in a way, it was going back to what social work should all be about. Really good relationship-based practice, really building trusting relationships as a professional with the individual and their family, but also being able to collaborate well with the other professionals and other networks involved with the individual and their family and carers, and really getting to the core of what matters to them. How do we build on people's strengths? How do we take a much more risk-enabling approach so that people really can be as independent as possible and have choice and control over what their lives are like and how we connect them to opportunities to be a contributor in their own communities and neighbourhoods, and to feel valued and included by their neighbourhoods and communities. And in that way, it's a really human rights, social justice approach to how we work with people with learning disabilities. And this came following on from the No Voice Unheard Green Paper, so we were very lucky to persuade the Department of Health and Social Care to invest in these pilots, and now I'm really pleased with the headline findings that are emerging from the pilot. So I'm looking forward to the webinar and hearing more about the evidence. Thank you very much.
Thank you, Lyn. Brilliant. So I'm gonna kind of build on what Lyn's introduction and just share some more about what the lessons were from the programme. But before I do that, I'm gonna ask us all to take part in a poll. So you've all really well kind of engaged with the chat, and I'm seeing lots of things coming up around what is the model and what difference does it make. That's the kind of the key messages that I think is coming through, and people interested in understanding what it means for them locally. It's also great to see. I've just noticed on the chat that we've got Shropshire and Hertfordshire who both took part in the programme, kind of joining and kind of participating. So they'll also be hopefully sharing some of their learnings as well. So the poll question that's going to kick us off, just to get a sense of kind of where everyone is understanding if you're interested in adopting a named social worker approach in your local area. And you might say, yes, we're already doing it. We've already got a named social worker approach. You might say that you're keen to get started, that you'd like to do it, but you don't know where to start, or actually that you're happy with the way that things are going already. And the final option for you is you don't know. You're here to figure out what it is. You don't really understand what it means. So the poll is now live, and I'm going to give you a minute or so to have a click on the poll. Oh, and it's going up very quickly, so we can get a sense of where is everyone, and where is everyone who's taking part kind of at in relation to this question. So we've seen quite a few people saying they're doing this already, quite a few people saying we don't know where to start, and quite a few people saying this is why I'm here, I want to figure that out, which is great. No one said that they're happy with the things that they're doing already and don't want to be looking kind of to do things differently or to kind of adopt new approaches. So that's great that everyone is here kind of with that ambition in mind. And I've also seen that someone's commented that that none of the questions fit the circumstance you're in. If you've got a different answer that you'd like to share with us, please do just kind of type it in the chat, and we'll see it from there. That would be great. Thank you. Great. So I'll let you. So the poll is now kind of in, and we're just having my colleague Steve is doing the sums and calculating what the results of this very scientific experiment have been. I'm going to now take us through some of the headlines about the named social worker approach. So the first thing I'm going to talk about is why a named social worker. And I think the first clear reason for a named social worker is that we know that too many people with learning disabilities, autism and mental health needs are not leading the life that they want. And we're seeing disproportionately poor outcomes despite the incredibly high costs associated with people's care. And on top of this, we know that the services and the systems that are there to support people are both complex and high-pressured, and that means that it's often hard for professionals like yourselves, like the people that are in the room today, to really think about, to imagine what a radically different and better way of working might look like and achieve. So we know from a whole series of kind of recommendations, from reports, from amazing projects on the ground, that there is a sense of what good looks like. And this is an example, so Stephen Bubb, who led the Time for Change report for the Department of Health. It's not that we don't know what good looks like. There's a real challenge about kind of turning some of this into reality on the ground. And what the Named Social Worker programme did, it was an opportunity to put what good looks like into practice. And so the Department of Health initiated, the Health and Social Care initiated the programme and funded 9 local authorities to participate. As Lyn said, there wasn't a prescribed model. It was very much built around the idea that sites should develop an approach that was relevant to their local context and tackle the local challenges on the ground for the specific cohorts of people that they were working with. And the question that the programme asked was, what is the contribution that social work can make to improving outcomes for people? Recognising the very crucial role that a lot of other stakeholders have in achieving these outcomes, and seeing the social worker in this case as a linchpin for helping bring all of those different actors together, whether that be the self-advocacy groups, whether that be the commissioning, the health professionals and services, the voluntary and community sector, existing large-scale transformation programmes such as Transforming Care, or wider governance bodies. And what we saw was two principal cohorts that the sites worked with, although they did work with other people as well. One group of people was those at risk of being admitted or already in inpatient settings, and the other was those young people approaching adulthood, and who often have kind of, as you all know, significant changes to the services, the people supporting them at those times, and for whom we know that our services don't always do the best that they could. So those were the two principal cohorts we worked with, but as I said, also working with wider cohorts as well. And I think we saw from the poll, and as I said, I've got the results just in. So we've seen that 39%, so that's the kind of majority of people, actually don't really know if they're looking to implement this, because they don't really know what it is. So the definition that we've come up with of a named social worker, and we'll go into a little bit more about the named social worker practice in a minute, but the definition is that the named social worker is a trusted supporter of people and their families with a real consistent relationship. So really taking on that responsibility for that whole family, for that person, and that consistency going through. The second thing that's really crucial about a named social worker is that they're the dedicated caseworker and coordinator, and it's not just caseworking and coordinating in the present, it's making the best future a reality. So it's always forward-looking and outcomes-focused. And the third thing that a named social worker is a voice of challenge and advocacy. So their job is to represent the person's wishes at all times, in all places. So I'm gonna go fairly quickly through these slides, but I'm gonna just talk quickly about what we did as a programme. So there was £1 million invested by the Department of Health, 9 local authorities who piloted the approach over 2 6-month phases, 200 people supported by a named social worker, and just over 25 full-time equivalent named social workers took part over those 2 phases. And I will send out the slides later, so you'll have a chance to have a little bit or more of a look at what each of the sites did. But the 9 sites that took part were Calderdale, Camden, Nottingham, Hertfordshire, Sheffield, Liverpool, Bradford, Halton and Shropshire. And we've got Liverpool here today to talk about a bit about what they did in phase 1, and we've got Halton here today to talk about what they did in phase 2. And in terms of the programme itself, the programme was supported by Innovation Unit, that's my organisation, and also by the Social Care Institute for Excellence, SCIE, who led on the evaluation. So what a named social worker does, I've shared the nuts and bolts definition of the named social worker earlier, but I think there's something really important in this about practice, and that a named social worker is about much more than what it says on the tin. There's being an allocated worker, and then there's kind of working in a different way with people. And you can use a lot of different words for it. You can talk about asset-based, strengths-based, person-centred, all of these words, but the named social workers had the opportunity to really push their ambition for the people that they support through the pilots. So as it says here, named social workers really get to know people, take responsibility for supporting them to achieve their ambitions. And we'll hear some examples of what that means in practice from the 2 sites as they present. But just to share kind of what the practice looks like, some of the learnings from across the sites, this is what we heard from the named social workers. The first thing that named social workers do, we really get to know people and we believe in them. The second part being very crucial, kind of believing in the opportunities, believing in the things that the people they support can achieve. The second is about confidence. So named social workers being confident to use their judgment to take the best course of action, moving away from a time and task, a tick box approach, to actually feeling like the professional in the room who knows the person best and who can make the best decisions with them and advocate for them. And we'll go on in a bit to talk about what helps build that confidence. The third thing is about deep knowledge, skills and expertise in working with people with learning disabilities, autism and mental health needs. There's a set of really important communication tools and approaches that people might need to apply in order to be able to really connect people and in order to be able to really get to know people, that move beyond, again, the tick box approach. It might mean taking the time to go, instead of just presenting someone with a list of options, it's actually, let's go and test out this day centre together, or let's go and visit this place where you might end up living and see whether you could make a home out of it, and actually engaging with people to see if to see people's reactions, where for example they're not going to be using verbal communication in the same way as we might. The other area of knowledge, skills and expertise is around legislation, and that's so that named social workers can feel confident using legislation, particularly the Care Act, in the transition cases, the Children and Families Act, Mental Capacity Act, Human Rights Act. Named social workers feeling so confident that they're able to bring the legislation into conversations and be able to challenge decisions that have been made. And there are a couple of sites that focus specifically on this. The fourth thing, and I'll go quicker through the next ones, but the fourth thing is about being able to advocate for people, and this is a lot about having that confidence in different settings to be able to make things happen. So it's the kind of the attitude, but also the confidence and the commitment to make things happen no matter what. So understanding what matters and then delivering on that with whichever professionals named social workers are working with. And the fifth is connecting the dots between people, services and the community. We know how sometimes it can feel very complex, very messy, a lot of the systems and services that are sitting around, but also some of the things going on locally, and it's how to kind of draw them together in a coherent way that allows the person being supported or the person who the named social worker is working with to feel that they're getting the best out of all of those services around them. A couple of quotes here from named social workers themselves. You have the time to think through their aspirations, how best to support them to be independent in the long term. You're not just thinking about the next year or so. And the second is about building confidence with those professionals who are around you. So the difference it can make. Again, we're going to hear some stories from Halton and from Liverpool in a minute. But just to highlight the different things that the named social worker can help achieve, we looked at what impact the named social worker would have on individuals and their families, what impact it would have on social workers, and what impact it would have on the wider system. And just to say, again, so this is within the context of a 6-month pilot where sites were kind of developing and delivering and evaluating within this time frame. So we're seeing a lot of early indications as to the impact that this type of approach can have over those short periods. So the first impact was people feeling they had someone who was really there for them, who's helping them live the life they want. And there are a number of examples of significant progress made towards their goals. For example, evidence of people being able to live the lives they want, including faster and smoother discharges from restrictive decisions overturned and greater stability of placements. And so those are kind of some big significant changes that took place as a part of the pilot. But we also saw things that might seem quite small, but actually had a huge impact on people's well-being and confidence. For example, we had examples of someone who was extremely lonely, didn't like going to the local day centre, which was the only option available for her, and actually what really helped her was getting a budgie and having something to take care of. So there's the kind of the large stories, and actually there's the small human stories that can be equally powerful and make an equally strong difference to someone's life. And we also had a focus on kind of thinking creatively about how you work with people to shape their plans, so that plans it's not a meeting that takes place once a year that's filled out in a document, but what are the other methods that you might use so that someone can fully own and fully be inside of their plan for their future, and that felt really important as well. And I can see Shropshire typing away, but Shropshire did some really interesting work in that space as well. So two quotes, one that shows the kind of softer side, you could say, my social worker is there for me, That's from a young man who's supported by the named social worker, just feeling like someone was there to support him in a way that hadn't been the case previously. And the second, again, bringing up the kind of human rights and the legislation, 90% of our cases found that the person either had capacity or was objecting to a placement, and that a number of cases now progressing through the Court of Protection to lessen the restrictions on the person. So the two kind of sides, the advocacy side, but also that relationship side, come through in these two quotes. So the second area of impact was around social worker confidence, skills and knowledge, and being able to use their judgment to advocate for people. And that was seen kind of consistently across, and we heard that consistently from the social workers who took part, felt much more able to deliver a person-centred plan, much more able to constructively challenge other professionals, and feeling much more satisfied in the work that they were doing. As Lyn said, a lot of social workers reflected back on, this is the social work we want to be doing, this is why we became social workers in the first place. So I've loved working on this pilot, as I feel it's given me permission to work in the way I feel I should be working, having more time to focus on the person and know what works for them as an individual. Getting it right for them gives great worker satisfaction as well as better outcomes. And the final area that we're going to look at is the impact on the system. And I know that I've seen questions popping up about this. It's what does it mean for the wider system to be working in this more intensive way? And we've seen that there's been better coordination of care, and the outcomes have improved. And there are a number of examples of care packages that have reduced in cost. As I said before, it's within the kind of time frames, we're not able to see those longer term outcomes, but what we are able to do is kind of understand what those longer term outcomes might look like. And as part of this, York Consulting delivered a predictive cost-benefit analysis that I'll talk about on the next slide. So we've had, as I've said, evidence of reduced costs for packages of care that we'll again hear about through some of the stories in a minute. We've had the cost-benefit analysis that showed a positive return of investment across all sites, and that was calculated at an average of £5.14 per £1 invested, based on a small number of cases, and as I've said, a predictive analysis due to the kind of short-term nature of the pilots. But we've also seen some impacts around how services are working together, better coordination on cases, better relationships built, and we've also seen other strategic areas being supported locally. So finally, making it possible. How do you do this in reality? We recognise that the principles are fairly easy to sign up to. It's hard to disagree with them, but there are things that need to be in place in order to be able to deliver it. And we work with the sites to understand what was it that helped unlock some of those challenges. And the first of those was protected time. So this was important. I've seen something pop up on the chat about caseloads, protecting time for social workers to work in this really deliberate way, this intensive way, and also to create spaces for reflective learning are really essential in terms of maximising the social worker's impact. And we can make a case that this is a wise investment rather than an unaffordable luxury. So peer learning is the second. Peer learning was hugely important in helping to build some of that confidence and some of those learning spaces that enabled social workers to be more, to take more risks and to be more creative in the support they offered, but also when things became difficult to help problem solve. So if this young person wants to stay at home, but everyone, the sensible thing to do, or the thing that we would usually do, is to take them or send them to kind of an out of area residential provision. Like what would it take to help them stay there? And I think there's a great example. There is a great example of this that I think it was Halton, where a young man's mother passed away, and it was what are the things that we can do to keep him in his family home that can really make that difference for him. So the third, reflective supervision, similar to the peer learning, and this is about how do you create spaces, how do managers create these enabling spaces? So it's not just about putting all the responsibility on the social worker, it's also recognising that supervision needs to be a space that's nurturing, that's reflective, and moving away from the kind of more transactional reporting models of supervision that can sometimes appear. Fourth is permission. One of our learnings that was quite powerful was that actually being identified as a named social worker brought with it a huge sense of permission and a recognised status, where there were no actual changes in kind of the legislative framework or any kind of job roles. Actually, people feeling like they were entitled to advocate in different settings because they were part of the pilot had a huge impact. And so that permission is really important. Fifth is about measures. Recognising that to kind of gain investment for these types of approaches, it's really important to be able to gather that evidence and be able to present that evidence. And hopefully we'll hear a bit later about how sites have used the evidence emerging from their particular pilots in order to make that case going forward to their senior leaders. And finally, the levels of ambition at a system level for doing things differently, for doing things better for people with learning disabilities, mental health needs with people with autism, and as we saw earlier, kind of 0% of the people taking part in this webinar said, no, we've got it, we've cracked this. So it's that need for a sense of ambition at a system level, as well as that ambition to do things better, the recognition and the understanding and commitment to social work's role in achieving this. So I'm going to stop talking now. I know that's been a lot of information to take in, and I'm going to invite the four people from the two local authorities who are here to share their experiences with the pilots to join us. You might hear a little bit of shuffling as we kind of move things around in the room. I'm going to start by introducing Halton. We've got Debbie O'Connor and Kim Lawson from Halton. You might want to introduce yourselves, and then I'll let you take it away in terms of what you did and what you achieved.
Hi everyone, my name's Debbie O'Connor. I'm the Principal Manager for the Transition Team in Halton.
Hi, I'm Kim Lawson. I'm an Advanced Practitioner in the Halton Transition Team.
Okay, and as you can see from our slides, the vision for us, we were in the second phase of the Named Social Worker project, which started in September 2017. And for us, we wanted to develop a transition service that kind of gave young people from the age of 14 and up through to the age of 25 the best positive journey through into adulthood. In terms of some of the background around that, we'd actually set up the transition team in February 2017. Following probably an example of fairly poor practice of a young man that had come through transition from children to adult services in Halton, where there was a lack of communication, there was a lack of planning, that people hadn't engaged with the family in any constructive way to look at what was going to happen when he did turn 18. And this was a young man who had very, very complex needs. He had autism, severe learning disabilities. He had behaviours that were difficult for his family to support him with. And there was a real lack of communication. And what we found is that lad kind of, in the couple of weeks before his 18th birthday, lots of people got together and panicked, if I'm honest, because we didn't really know what the plan was going to be. And I think we got to his 18th birthday, and sadly that young man, Paul, ended up going to a very costly out-of-area placement, which was quite a long way from where his family had lived. And we realised throughout this whole process that this was not a good plan for Paul, and it certainly wasn't for his family. He was very fortunate, and we were very fortunate that he had a fantastic parents who came and sat with us and did a presentation to us as to what had gone wrong, really, in terms of that transition. And we sat down as a multi-agency, and through our health colleagues, education, through children and adult services, and we did an action plan, and we looked at all the areas that had gone wrong for Paul's life and in terms of that transition, and all the reasons why we'd ended up going into an out-of-area placement. And the majority of it was that we hadn't planned, we hadn't worked together, we hadn't communicated with each other. So we went back to our senior management team, and we got an agreement to sign up a couple of adult workers and a children's social worker, and that's how we set up the transition team in Halton. And it was really positive, because it was just that couple of months before we then made the application through for the Named Social Worker project, and we were successful in terms of getting the application. So for us, we definitely wanted to kind of create some lasting relationships, and we wanted to have families that would kind of trust us and support us, but we very much wanted to have a new approach in terms of working with these young people themselves. And when we'd spoken to the young people, what they were saying was actually they didn't feel that they were engaged with. And when they'd had their school reviews, very much it was in a 15-minute process with lots of professionals sitting in a room, most of which they'd probably never met before the review, and they had 15 minutes to get across exactly what they wanted their future to look like, when actually for all of us we would be quite daunted by that process. So what we did is we kind of came together with this cohort of 17, 18-year-olds, and there was a group called Bright Sparks that came together, and they were from our Halton self-advocacy service. And they worked alongside us right throughout the named social worker process to talk about what they wanted transition to look like. And they did some very visual drawings, they gave us lots of verbal feedback, and eventually we got the funding through the Named Social Worker project to create a film, and they did their own script, and they actually developed a transition video, which I'm sure we'll be able to get out to everybody, and it was fantastic. It was actually their thoughts on what they wanted it to be, and it kind of stopped that us professionals in our tracks to say, we're not going to do this 15-minute bit, we're actually going to work with people beforehand to think about what they want transition to be, and for them in terms of their own dreams and aspirations, for us to kind of support them to get to that situation. We wanted to work with young people and their carers to actually make some very difficult decisions as well. We worked with one particular young man who'd been in the care system through the majority of his life, and he'd ended up in various out-of-area placements, very, very costly. I mean, at one point it was £15,000 a week, and that was due to escalating behaviours on his behalf. At one point he had 5 staff that were trying to support him because his behaviours were so difficult to manage. And for him, James and his family felt that they were finding it increasingly difficult to trust professionals in terms of making the right decisions for them. So for us, the named social worker approach was fantastic because we were able to have a particular worker that would work with that family and develop that relationship that would be based on trust. And there was a commitment from us that we would listen to some of the very uncomfortable things about what services we had provided for them in the past, and for us to kind of say, no, that wasn't right and that didn't work, but actually to trust us to make some decisions that would be very person-centred for him for the future. James had a personal health budget, and we wanted to look at some very bespoke services that were for him would be all the interest that he would have. So he was very interested in rugby, he was interested in football, he wanted to keep fit, he wanted to go to the gym, he wanted to engage in his community, but most importantly he wanted to live closer to his family, and that for him was most important. The difficulty for family was living closer to them. That the worry would be that there would be lots of behaviours that they would probably struggle with. And while he was living out of area in what would deem to be a safe and secure environment, they felt that that was the right decision. The longer he stayed in that out of area, what would be described as a safe and secure environment actually proved to be the total opposite of that, because actually he wasn't engaging with the care staff who were not engaging with him well. The police were coming out on repeated occasions. He was getting arrested on an almost daily basis. So eventually family realised that they needed to take that gamble, but they got to a situation where they started to trust us, that we were making the decision because we thought it was in the best interests of James. And we're glad to say that he's kind of been living back in Halton now, and within our 10th, 11th week, and we've had the police house on one occasion in that 11 weeks, and that had gone from having the police house on a daily basis. His relationship with his family is fantastic. He's meeting them on every few days. In Halton, they're going swimming, they're going out for tea. He's actually on holiday at the moment, and we're actually planning for a family holiday for next year where the care staff are actually going to go with the family and James, and they're going to have a first family holiday they've had since he was under 5 years of age. So this has kind of been a fantastic example of kind of how working together and developing that trust. And in all of that, there's been £11,000 a week saving for the local authority and for the health authority. So in some ways that's the side issue, but that's a phenomenal saving for a service that actually, for a fraction of the cost, is improved James's life and his family's life immeasurably. In terms of the support the social workers to reflect, in terms of, for them, if I'm honest, I feel like in social work, when the Community Care Act came out, we lost our way a little bit. We kind of became process driven. We did assessment, care management, review and close, and we forgot how to talk to people. We kind of got driven by assessments and documents, and I think the named social work approaches has allowed us to kind of reclaim social work. And as a team, we've kind of come together and we know about each other's, the people that we're trying to support, we all know about each other's cases. And we do group learning sets. We've allowed each other to talk about uncomfortable decision making, and we've reflected on that and thought, you know, did this work well? If didn't it work well, why didn't it? And what we could do differently. And we definitely have called this kind of our shared team brain, which we'll talk about a bit later, but that's kind of definitely how we've worked that. But the social workers have developed a much greater confidence, and that's because mainly when we did our old care management approaches, you actually don't know people very well. You know what you've ticked and what box you ticked, but you don't know those individuals and you don't know their families. So when you go into meetings now, you've got a greater sense of confidence because you understand what the needs of that family are and who they are. I think we've been able to build a much stronger foundation for an integrated health and social care planning through the named social worker model, and we actually have our complex needs nurse based with us within our team now, and we sit alongside our positive behaviour service, and that together it's not just been about the social workers, it's been that integrated model, and we've definitely had sign up from our colleagues in education, and they've wholeheartedly supported this process because they knew it wasn't working. All of us knew it wasn't working, so there's definitely been a sign up from everybody to want to work with this approach.
Yeah, so I'm going to speak about, this is Kim Lawson from Halton. I'm going to speak about Peter and his journey and my involvement with working with Peter initially. So I started working with Peter when he was about 16 and a half. At the time he was in a specialist education provision, and I was attending the school meetings. It became apparent at these meetings that there was quite a lot of issues with Peter in terms of his attendance and his relationship with his family at home. So I started the assessment process with Peter and had involvement with the children's social worker. His family had had a lot of involvement from children's services over the years for Peter, but also his two other siblings as well. The family had experience from multiple social workers from the children's teams for the different children, and they had quite a negative experience with the social workers from children's, just due to the fact that they never had consistency, and it always appeared to be a social worker would come to one meeting and then potentially it could be another social worker for the next meeting. I started my input and I visited them Peter and his family quite a lot at home, but also at school as well. But it was around this time that Peter completely stopped attending school. He just didn't want to go anymore. We weren't really sure on the reason for this, but at this time I then increased my involvement. So as a sort of part of the course, really, what we would then do is get all the different agencies involved to make sure it's a multidisciplinary approach. So I made referrals to the learning disability team nurses, speech and language therapy, positive behaviour support, and at this time as well there were also the long-term discussions that we were having in terms of what was going to happen with education, what the impact of his health conditions were, and what was going to happen with housing as well. Mum was absolutely adamant that she didn't want him to go into different housing, she wanted him to remain at home. But unfortunately, due to quite a lot of incidents happening at home, and the stress levels at home, it come to the point where there was child protection issues with the other siblings at home. So it was felt that potentially it'd be better for Peter long term to move out of the family home. So I'd been working with Peter at this point for probably about 12 months. So I had built up quite a knowledge of how he interacted, how best to support him. We were at this point we were working with a particular agency that he worked with well, so we felt that potentially it was a good time to move Peter into a accommodation that was out of the family home but supported by people that knew him well, and also to have input from the family. So it was going well up until a certain point, but as with our team, the transition team in Halton, we do have, as Debbie mentioned, we jokingly at one point used to call it the shared brain, but we genuinely have group discussions about the cases that we have within the team. And this worked really well in this instance because I went on annual leave for 2 weeks, which is often the time when things go really wrong. But there was a particular quite severe incident that happened within the accommodation with Peter, and the support staff that were in at the time felt that they could no longer support him in this accommodation. So it became to a crisis point, and Peter's behaviour kind of deteriorated to a point where GPs were involved, and he was being assessed for potentially had to go into being detained under the Mental Health Act. But luckily, a colleague of mine, Lisa Cookson, because she knew the case so well, because we have sort of these group discussions, she was able to quite easily sort of step into my shoes really, and able to then work with Peter and his family to then move him in quite quickly into more long-term accommodation with a different agency that luckily was able to pick the package of care up very quickly. Now initially this package of care was very expensive. He needed to be supported by 2-to-1 support through the day and night, and also his activities were very heavily risk assessed just due to the challenging behaviour. However, with time and with positive input from all the different agencies, including the learning disability nurses, the speech and language, community bridge builders, positive behaviour support, the instances of challenging behaviour began to reduce. And it's got to the point now where Peter has a reduced package of care, or package of support at home, which is enabling him to lead a more fulfilled life. He's able, he does still have 2-to-1 support, but he is able to go out more. There's lots more interaction in the community, and now this long-term plan is for Peter to go back into education, which wouldn't have been considered about 12 months ago. So Debbie's just going to have a quick discussion about the cost of care in Peter's, the initial cost of care, and how potentially how much it would have cost per year.
I think the named social work approach was actually really good at allowing us to think about the wider picture. It wasn't just about the cost in terms of the impact on social care, but actually the wider community costs that we're having. And for Peter, throughout 2017, the police has actually been called out on 26 separate occasions. And there wasn't just the impact of those police calls, but it was actually also about the impact that had on children's services. This had been a family that had been involved with statutory children's services, health visiting services. There'd been lots of wider costs that were related to this family. And actually, none of it was actually working in a very person-centred way with the family. And what we were able to kind of break this down in terms of, in 2017, there was call-outs of ambulance services on 5 occasions as well. And then all of that would then be kind of have an impact on our emergency duty services, on the police. And then they would come through over to, when you came over into adult social care, then the feeling was that we would end up in a situation where we would end up kind of looking at mental health type support. And for people who probably know that, for people who are sectioned under the Mental Health Act, there's significant costings to that. So for 28 days, you'd be looking at 14,420 is kind of as the breakdown. And the majority of people who end up in our long-term services within mental health services don't normally end up there for just 28 days. The chances are they can end up there for up to 5 years, and it becomes very difficult because people do become institutionalised, and then it becomes harder to have that transition back out into services. So that we were able to do some costings in relation to what was potentially a cost avoidance for the wider health and social care services, and that broke that down into nearly £188,000 had been the impact of who'd have ended up in a long stay hospital, which wasn't, this was a minute away from the service that we're providing, and instead Peter's current care package has kind of been at, initially it was at £5,000 a week, and that was 3 to 4 staff, and then as time's gone on over the last 12 months, we've reduced that further and further down, and that's gone to £2,910 a week, but there is still continuing changes to that care package, and that will reduce. So that's 151,000, which we know is an extortionate amount of money, but actually for Peter, he's got a really good quality of life now, and actually the alternative to that was actually a much higher and a not a good quality of life.
So the intensive and creative support to individuals, it is an intensive amount of support that you have to put in initially to get to know the person, to complete the assessments, and also to make appropriate referrals to different teams and to give the relevant information. But with this type of work, there are periods of intensity, but also there are a lot of periods where the package of care it can be very well managed and controlled, and there are periods where it can be a lot quieter, so it isn't as intense all the time. In terms of creative support, to speak about another case that I worked with in terms of respite, a gentleman that I was working with, his respite was in a respite facility that was quite a long way from where he lived, and that just wasn't working for him. It was very expensive. It was about £7,000 a week. But thinking creatively, being able to work with him and his family for quite a long period of time, we came up with the respite where Mum had a caravan, so Mum went to the caravan and we used the respite element of his package of care to support him within his own home, with support staff there. So that was just thinking creatively, rather than him moving out of the home. He would stay in his own home where he was more settled, but that enabled Mum to have respite.
Thank you so much, Jim and Debbie. There's so many examples to go through, and I know you've already touched on the kind of multidisciplinary element, the shared brain, and some of the principles we'll bring out in the conversation in a minute. But I'm keen to make sure we get a chance to hear from Liverpool as well, and to continue this conversation with all the amazing questions, comments coming through. One quote just to break us up a little bit that came through from Portsmouth, Mark Cameron. I know that they've been implementing this model for a while, since before these pilots. That he says that we need to move from the paternalistic role, we need to build confidence, and we need to empower choice. So with that, I'm going to hand over to the team from Liverpool to introduce themselves and share a bit about what they did actually as part of phase 1, and then what that meant for phase 2 as well.
Okay, so I'll start off. So it's Martin Lawson, college manager. Then on my left is
Lindsay Constance, team leader.
Okay, so you just heard about the fact that we were involved with both phase 1 and phase 2, but today we'll just concentrate on the phase 2. Phase 1 of the pilot. That was back in the phase 1 started in October 2016, and we concentrated around the LD transforming care agenda. As an authority, we were unfortunate at that time an outlier in regards to adults in and out of very long stay bed. We had at that time 26 adults in that situation. So obviously we wanted to concentrate on how we would enable those people to be discharged from hospital. But the key aspect for ourselves, for ourselves, was to try and rethink what the actual social workers were doing in regards to their practice, what were their relationships, and that was to then bear in mind some of those key drivers at that time. So obviously from 2014, we had the Care Act that were brought in, which changed that whole landscape of how we operate social services itself. Again, locally, we had quite a number of adverse incidents and complaints in regards to these types of new situations. But again, I think locally one of the key things for ourselves, where we'd gone from having an LD team that would obviously just specialise with the LD cohort to having in fact more generic teams. So with that, there was that dilution of that skill mix of that knowledge base that we needed to try and review and see how do we in fact create better practice for social workers trying to support adults with LD needs. So that's the context of the phase 1.
Okay, so the named social work model in Liverpool consisted of 1 team leader and 3 named social workers. The aims of the pilot were to look at the assessment process, so exploring social work practices and establishing a new framework of assessment for inpatients. We wanted to capture an individual's voice, their strengths, their aspirations, as well as their eligible needs. And at the same time, involving partners at an earlier stage to develop robust and realistic support plans. We looked at relationships, so experimenting and developing best practice in working with individuals and partners from across various agencies, so our health colleagues primarily, and getting them involved earlier. And also we wanted it to be a lasting legacy. It was only a 6-month pilot and we didn't want that to be it. So for the legacy element, we built on the skills, the knowledge and experience of the wider neighbourhood teams to provide high quality social work with people with learning disabilities.
Okay, so I think today we've already talked about issues that have gone on, I think, historically around social work with the what was the Outcome Care Act, that we felt local social work had in effect become, I think, much more transactional, and we wanted to get towards more of a person-centred approach to how we do social work and what good practice meant for social workers. So for us, the key part of that phase 1 was then trying to unpack good practice through things like reflection, again through having things like peer support sessions with our staff, to try and look at that golden thread of support from senior management team to staff on the ground floor, as to try and ensure that practice element of what we did was clear throughout all that we discussed and operated. So again, as part of that, we then looked at, as part of how we help staff to unpack, in fact, some of their core practices, to unpack what was a good assessment, but also what was an effective relationship. What that then informed was how we then all try and learn together as no authority. So we actually embarked on a whole training program that in effect focused on our team leaders, because we felt that was the key area in which to try and effect positive change. So to try and unpack what was good practice around trying to work with people with complex LD needs, and to try and support team leaders who perhaps hadn't worked in that area before, to try and give them the skills, knowledge and experience for them to then support their staff in trying to do the same. And the key around that was to try and enable team leaders to understand the nature of what good look like, to ensure that we can all operate good practice in all the teams. We also looked at enhancing transforming care agenda itself locally by setting up the what's now called tracker, I think risk register meeting that we have now weekly, and that's where we have no authority come together with our LD Trust and also CCG to discuss that whole transforming care agenda. In fact, we met last week actually, and that does appear to be going very, very well. That is, for ourselves locally, is a key legacy stronghold. And again, comments from leaders in CCG has offer reference to that as well.
So looking at one of the journeys of one of the individuals that we had on phase 1, the pilot, they'd been known, they'd had a history of being known to services for a number of years. The individual, Stephen, had complex needs, including a learning disability and mental health, a forensic risk profile, high risk, had lived in various types of community settings, none have been successful, and it had resulted in a number of admissions. At the time of the commencement of the Name Social Work pilot, Stephen had been an inpatient for 2 years with no room really for moving anytime soon to the community. So an NSW, the Name Social Worker, was allocated, and then what he did was establish an effective relationship built on trust and transparency and communication with Stephen and key partners. We involved health early on in that, which was key. A strengths-based assessment was completed, building on the assets in Stephen's life and his aspirations. At the same time, working with partners to develop positive risk management plans to optimise community living in a safe and valued way. So the outcome for Stephen, he was discharged in January 2017. He continues to live successfully in the community, so that's a real achievement for him. We have prevented hospital admissions. We've been able to react appropriately, jointly with health, as all involved in facilitating discharge in the first instance were all aware of what was expected of them at a time when Stephen was in crisis, so we have successfully managed him. He has more formal and informal networks of support, working well to enhance Stephen's independence, well-being and optimising his assets.
I think the key, sorry, for that case as well, that the NSW who was involved with that case, he got to know Stephen really well, and for us that was one of the key aspects of the whole NSW approach, is having that great, that depth of understanding of our service users. I think previously that just doesn't happen in the depth that you'd hope. So, okay, as part of the phase 1, we also looked at the actual financial impact as an authority. So, out of the 26 individuals in the Altiveri placements, we were able to discharge in that timescale 7 individuals. What that has led to has increased partnership working with ourselves and also Merseycare, who's the trust locally, but also CCG. Because we've all had to think more creatively in regards to how do we enable somebody who on paper is perceived as being really complex, risky. What do we need to do differently to enable that person to then live successfully in the community. So what we've done ourselves and health, we've now actually commissioned services locally to, again, it's to trying to take this whole agenda further by trying to support people that are complex into what's called Better House, which is our new service that we've commissioned that's due to open in October this year. So we've got plans now against all people that are currently in the Altiveri placements. We have plans now against all of their inpatient stays to try to support their discharge in the coming period. In terms of the cost analysis, unfortunately I can't read that for me.
Yeah. The key number is scribbled out on the screen.
It is.
I don't know why.
But in effect, we're able to save, I think from memory, it was about £1.5 million we were able to save during the period of the first phase of the pilot. And obviously that's not, that isn't being saved to us as an authority, but in terms of that public purse, there was a saving, which I think is quite a big saving to make in that period. But obviously, the actual real impact, real impact, is for those individuals where they've gone living within a hospital setting where they've got a lot of restrictions. They're either on a dole or on the MHA, to then actually living in a community setting where their human rights themselves are being fulfilled, which I think is really is critical. But also the cost part of that was really critical as well.
Okay, so for Liverpool then, the impact of the Name Social Work pilot has been to ensure the learning and best practice from phase 1 is embedded into the wider neighbourhood teams. We've extended the learning outcomes from phase 1 to work with young people with complex needs preparing for adulthood, so we took part in phase 2 and looked at our preparing for adulthood services and aim to work with young people from the age of 14 plus. We work in collaboration with young people, parents, carers, social workers, partner agencies, services to develop effective assessment tools and one that is co-produced and designed to facilitate a positive journey into adult services and adult life. The named social work role is being implemented into the neighbourhood teams as well, so every case in Liverpool will have a named social worker, so even our community teams, not just the learning disability team, service users will have a named social worker. We want to embed the asset-based assessment and approach, so we've already commenced on the training with the social care workforce to embed that in practice. So the key principles of the named social worker is embodies best practice in social work and acts as a key connector across multiple agencies and systems.
Okay, so as you've heard at the start, we were involved with both phase 1 and phase 2, and the key part of the phase 2 and the link was we felt that we were able to realise a lot of positive change for adults with LD, and therefore we, again, through issues around complaint and adverse, we wanted to try and thread that into how do we support children going through transition. So our vision essentially for phase 2 was to effect a new transition journey for children to adult services, but to try and build on their strengths and aspirations, as we did for the phase 1. So from that we've done a whole piece of work around transition, around policy development, and also we've adopted the PFA framework, which you may have heard of. It's the Parent for Adulthood framework, to in effect benchmark all the various things that we've done in that phase. That's basically it. I think for us locally, the key thing now going forward is the fact that we are going to roll out the NSW role. What that means is that every service user who has a care package in the community will have an allocated worker. That, in theory, will bring challenges, but what we've tried to do is to create the environment of support and to enable staff to have the skill base and the confidence to then be able to do good social work, which is critical as part of that change, really.
Brilliant. Well, thank you so much to Martin, to Lindsay, but also to Debbie and Kim, who you heard a little bit earlier. We've got about 15 minutes now for questions and discussions, so we've been collecting them as they've been coming through. But now's your chance to find out more. So if there's anything you'd like to know about the named social worker approach, please type away. We've only got 15 minutes, so we won't be able to get to everyone. But I'm going to start with the question for Halton, because Liverpool just kind of ended the conversation or their discussion with a bit of a picture about what's next for them. So it would be great to get a perspective from you about what's next in Halton.
There is definitely a commitment, particularly from our adult director from Halton, to have a continuation of this model. We are looking to roll out the 3 conversation approach for Halton, and for the stage 3 of the conversation for the people who end up in our complex needs, because that will continue, is that all of those people who are within long-term complex services will take on the named social worker approach. So there is a continuation for that, but also from a multi-agency approach, we have what's called the One Halton Board. So I will be doing a presentation for them to the chief execs of the CCG for the borough councils to talk about this approach and to roll it out across other parts of social care for them to understand, and for people who are particularly in long stay hospitals, and how you can have the intensity of a social worker can maybe support people to leave long stay hospitals on an early. So that would be for mental health and LD services.
Brilliant. So focusing in the pilot on transitions, but now asking the question, where else can this be relevant? And that's one of the questions that has come up earlier. Someone asked the question, where else? Two questions, and then you can answer both together. But one is, where else can this apply? So can it also apply to mental health services, for example? Can you imagine it applying in different settings? And the second is, who else can it apply to? Is it a purely social work role, or are there other professionals who could be involved? So I'll start with Liverpool to answer those 2 questions.
So going back to the point whether this is is to focus around LD or mental health or the other areas. I think, again, from the phase one, we were very, very clear that this is that there's nothing special around the NSW role. It's good social work practice, and that has to be spread across all areas of need, not just LD. I think the bit that's challenging is around challenging need, or that's a complex end of need, and that's where I think all authorities struggle in trying to manage those complex factors of an individual and their whole network of support and so forth, and how that's done. So for us as authorities, not just us within our city but elsewhere, it's trying to ensure that we create that environment to then support staff to try to support complex needs. But for me, it's an all-catch phrase, not just around LD or mental health.
I think for us, we kind of flipped it around. With one of the cases in our cohort of 17 young people was a young man that probably prior to the Care Act would not have been eligible for social care intervention, and we were able to use the prevention element of the Care Act to say why we wanted to support this young lad. And he was someone with incredibly mild learning disabilities from a very chaotic family, and he didn't want a social worker. That was probably the last thing he wanted in his life, was to have a social work approach. But he was kicked out of the family home, and we knew straight away that he got involved with the undesirables of the locality. So for us, having that intervention, which was very intense, we helped him to get his own place, we helped him to get his standing orders for his gas and his electric and budgeting and food, and we actually were able to support him to move on. He doesn't have a social worker now, he's actually got a partner, and he started in long-term education. So for him, that's a fantastic story, but I have no doubt if we hadn't used the named social work approach for somebody who probably wouldn't have been eligible 2 years ago, he would have ended up in the criminal justice system. So that again is a wider community saving.
I think we've had similar cases in that same context where the concern was that if we don't intervene, this person will probably end up in that criminal justice route. So it's a case of who needs to do something, and it does.
And it's looking at those cases where it feels like things are bubbling up, and there's a lot of things involved. There's complexities involved, as opposed to going down the diagnosis. Absolutely.
Really. And I think in some ways you have to look at presentation and what the person's needs are rather than what the identified diagnosis is, as you say. Because we live in a different world now, and some of the people that we work with have got people who've got fetal alcohol syndrome, and that doesn't fit into your normal learning disability category, but the actual impact on society and for them is massive. So it is a change in face in terms of need.
And can I ask the second question, which was about then, if it's for this cohort, we're talking about a cohort with complex needs, who does the professional need to be a social worker? What does the social worker bring that's distinct?
Good question.
We were actually saying that we think there could probably be some unqualified staff based within the named social worker model within the team who could do, so it could be overseen by a social worker. But actually there's some very intense responsibilities and roles and support that an unqualified social worker or a nurse or anybody else, and to be fair, we've got a nurse based within our team and she's done some very intense work that you would definitely describe as part of the named social worker project.
Great. So I'm going to read a question from Anne Flanagan. She's interested in understanding the kind of level of financial investment, so this is going to be a challenging question, and how you manage the tension between protecting time to work on some cases whilst also being mindful of the other cases that are coming in, the waiting list, the reviews that are overdue.
My personal belief is that it's almost impossible to do this model within the existing structures the way we work with, and some of the work that I'll be doing in terms of going to the Halton One board is an invest to save model, so to look at the huge savings that Halton have made and the changes in people's quality of life within this model, and to actually invest some of that money to actually employ social workers. So we've got one young man who's been out of area for 6 years now. Actually you can afford with this model to invest one social worker to work with that individual and change his life. So for me it is hard to balance the intensity of this role with the day-to-day work of 30 odd cases in a caseload. It's almost impossible to work with that. I think we have to be honest about that because we have to protect our staff's mental health as well as our clients.
And I guess that's where we start thinking about the system and how has the system been built. And actually, if we're ambitious at a system level as opposed to it's the social worker's responsibility to protect their time managing all these different cases. It's actually what's the practice implications and then what's the system implications for this way of working.
Yeah.
Any reflections from Liverpool?
I think in regards to cost and investment, the fact is that all authorities have been faced with a cut in spend, and that's the way things are. But I think it's how do you do things differently with what you've got. I think it's then around knowing what is good practice, what are the key ingredients to good social work, and I think for us it's about I think part of that, is to ensure that we have that environment of learning, of peer support. So we're now looking at how we actually set up that whole sort of peer support network with the advanced practitioners to see how we can share learning across different teams, and that itself should enable and enhance skill and knowledge.
Brilliant. So I'm looking at the questions that are coming up again, and we've got a question come through from Chris Hatton about the kind of knowledge of the law, the human rights legislation, the Mental Capacity Act, and how that fits with this question we had before around the kind of social work role. I wonder if anyone has anything that comes up for them around that.
Working with Peter, we had to do quite a lot of intense work around the Mental Capacity Act and best interest, and with a multidisciplinary, multi-agency approach that was crucial, because we used the speech and language therapist, but also learning disability nurse, and having that knowledge of the Mental Health Act enabled us to do, obviously, the very intense assessments that you need to do around the Mental Capacity Act, but it's also that the MDT approach enables that to be an easier process rather than it being hard work, being able to get other professionals. If everyone's singing sort of from the same hymn sheet, everybody has a joined up approach.
Yeah.
I think that's where, again, we talked earlier about the whole invest to save. To have a whole workforce that has access to the right training around that whole legal framework is critical.
Yeah.
Now, whilst there's no cost benefit at the end of it, there's no reduction in spending, but actually it's ensuring that staff have the utmost skills and knowledge to be able to do what we need to do. And that's what, again, we've done locally, is try and capitalise on the key ingredients to do that, to ensure that staff are equipped to do what we're asking them to do.
And I've just seen that Susie from Shropshire has kind of reiterated that point. With our newly configured transition team, we recognise training is crucial.
Yeah.
So there is a specialist level of skill, and then I think Bradford, working with the University of Lancaster, worked on a kind of a skills framework, knowledge and skills framework for advanced practitioners working with these cohorts. So I'm going to ask a more practical question now as the last question, and I wonder if actually, because it's quite helpful to have around the table people at kind of different levels, doing different types of work in this space. So from all of you put your kind of role hat on, and you could have a quick think. I'll give you a couple of seconds to think about what if to speaking to someone who was in the same role as you in another organisation. So whether that's a frontline practitioner, team manager. What advice would you give them if they were interested in taking on this role? What advice would they give them? That's the first question. And the second is, what would the first thing you told them to do would be, or recommended that they would do would be?
I think for me it would be to talk to
Do you want to just remind us what your role is as well?
Sorry, I'm Debbie, and it's in Halton, and I'm the principal manager of the team, so it's kind of middle management level. So before you can even think of taking this approach on, you have to have sign up from your directors, and most importantly from your colleagues across health, housing, education, children and adult services, in particular in relation to transition, but in relation to other services, whoever your partner agencies is. This will only work unless there's a commitment from all agencies with this approach.
Yeah, I think for me, it's Lindsay from Liverpool. I'm a team leader in Liverpool. I'd back that up as well. I think know who your key partners are in the CCG, your commissioning teams. We'll look at the services that don't exist. Yeah. So it's about developing new services as well.
Brilliant. And Kim, from a practitioner perspective, what's the thing that helps kind of that shift?
I think it's for, as I said before, we jokingly called it the shared brain, but our team is a very close-knit team, and you're working so intensively with different individuals, and it's important that the team has the approaches. It really is a team approach. So we generally don't know the ins and outs of every single case, because that would be very difficult to manage. But if one of us is off, or there's a day where somebody's on duty, we do know enough about the team cases to be able to continue to work with that person until either the person's back or the social worker's back. But that really does make a difference in terms of consistency and enabling trust and confidence.
Thank you. Martin?
I think the points that have been raised, I would mirror those thoughts really. But I think one of the key things is I think to embark on this journey itself is a challenge, because it forces you as an authority to go back to basics of what is good social work. I think that there's now I think it's a greater cry for authorities, to really think about what are they doing as authorities, how do they operate good social work. I think that for us, these 2 phases we've been through have really forced us to do that. It's been challenging, and as I say, we're now going to embark on the premise of this role going forward. But that's to be reviewed. I mean, we'll have to then see how that rolls out and what the impacts are going to be. But critically, it's fair to say we see the value of having an NSW. The fact is, it's difficult to provide good social work without that. I think that's one of the key things.
Brilliant. Thank you for your perspectives. And just to share, again, I can see Shropshire commenting there has to be passion to work in this way. So that's the key ingredient. That passion, that ambition. And then another interesting comment, helpful comment from Mark, it's not just about funding, it's about the mindset, how we're approaching it, and having relationships at the heart. The business case is important, but the relationships are at the heart. So thank you so much. We've got 15 minutes to go, so what I'm going to do now is I'm going to say thank you to all of the participants. Thank you for sharing your stories, your insights, and we're now going to have another poll quickly before we close up. So you've heard some examples about what this looked like on the ground for 2 of the sites. There were 6 sites. There were different approaches. You've heard from me some of the kind of headline learnings across the programme about both practice and about some of the kind of practical things that need to be in place. And we're going to ask you the same question we did at the start. So you've heard all this information. I can see comments down the side, lots to take in. Now you've heard that, do you still think you're already doing this? Does this reflect the work that you're doing on the ground? Is it something that you've heard and now you think, yep, we're keen to get started, we're ready to go? Do you still feel that you're not sure where to start? Do we now have some people who think, actually, no, we're fine, thanks, this is all good? And then finally, is it still an unknown, still lots of exploration to happen? So again, a couple of minutes for you to click away at the poll. It should be live now. Yeah. So as you're clicking away for the final minute, I'm going to invite Tony Hunter, Chief Executive of SCIE, who have been partners with Innovation Unit as part of the programme, to sum up everything we've heard and share his reflections on sort of what next for the name social worker. So just wait until the final results are in. I think from a quick glance, I can see that, again, everyone is ambitious to do things differently, so we've got no one saying everything's fine. We've got 12% of people saying still not really sure, still trying to figure that out, down from 39%. And then we've got a pretty much equal number, so almost a third each of people who say either we're doing this already, we're keen to get started, or we like the idea but we don't know where to start. So thank you for everyone for participating in that, and I'm gonna shortly hand over to Tony.
Okay, well, great. It's been fantastic participating in this, both in the overall project and in this webinar this afternoon. So thank you, everybody. It's been so much to sort of follow and jot down and so on, really. I think the theme for me comes back to what Lyn said at the start, and so many of you have echoed about how this really is about good. It really is about good relationship-based, collaborative social work. As you said, Lyn, understanding what matters, building on strengths, enabling people's contributions. It's so fundamental, really. And clearly, this way forward has helped from the person's perspective. People felt, as you said, Chloe, people felt they had someone really there for them. And for the impact on social workers, confidence, permission to test, challenge and so on. And the enthusiasm from colleagues at Halton and my old stomping ground, Liverpool, has been great, really. Some of the comments from up here, I think, Katie, you made comments about reminding us of transforming care and of preventative approaches and so on. And, it makes me think about how we link this with all the other initiatives that are taking place in authorities and systems locally to transform people's experiences. How does this link with community navigator schemes, community mapping, innovation and so on, really, which all too often have different momentums. Katie, I think you the one who was psychic, or was it Paul Carr? I can't remember, one of you anyway. Recognising the pressure in local authorities, but optimism, this approach is actually going to help over time ease the burden on services and promote better outcomes. Yannick, you were sharing personal experiences as a mother and helping us focus on solutions. You were saying, is this solutions based? And I think it is, but we've got to keep the momentum going on that. Mark, you were very pleased about Mark Cameron delivering the named social work role in a fully integrated team with a caseload of 43 people. Even though you said it's about complexity, not necessarily numbers, even so, perhaps it shows what can be done. And Paul, Paul Carr's emphasis on allowing more scope for positive risk-taking, which Lyn referred to at the start, but we didn't get into too much during the conversation, I think. So the great exciting thing for me is where from here, the organisational learning, how do we embed the best of what we've learned so far? And perhaps what were the limits of the named social work scheme as named social work opportunities as well? What could people find that they couldn't do with hindsight that they'd like to be able to do with this? So there's lots to talk about, lots to take further. And again, thank you everybody for enabling us to participate.
Brilliant. Thank you so much. That's great. A great kind of summary of a wealth of insights, a wealth of conversation. Before we end, we'll end in a couple of minutes. I just wanted to show you, and the slides will go around with the links where you can go for more information going forward. And if you want to find out more, I've seen lots of people coming up and saying, I want to understand more. What does this really mean? And kind of how do I take this forward in my area? So there's some reports. There's a report, a kind of practice guide based on the learnings from this webinar, putting people at the heart of social work, lessons from the programme, where you'll see lots and lots of examples within there. There's a summary evaluation report, and there's also a full evaluation report that SCIE produced, looking more at the impact that the programme has had. And then there's a set of resources and tools that have been developed as part of the programme. So I saw someone on there was asking about an assessment tool. There are other kind of tools that other sites have used, kind of collated together within that pack, as well as a guide. And I've also seen a comment about kind of how people and families were engaged in the programme. There's a guide that we developed for the named social workers in terms of helping them to engage meaningfully with the people that they're supporting. And finally, if that doesn't answer all your questions and you are interested in finding out more or thinking about what it might mean in your local area with the specific challenges that you're facing, then please do get in touch. You can see my email address on there. And I'm really, really happy to have a conversation with you about it. So thank you so much everyone for participating. We've had very, very welcome response from everyone who's kind of tapping away on the side in the chat, and so that's really, really great to feel like that there's more of us thinking about these questions. There's a lot more of us than the 7 of us in the room. So thank you so much. I hope this has been useful, and I hope that this is going to help help you take the next step as you go forward to support people in your own communities. Thank you.